We'll get started. Welcome everybody to this is our third session in our primary prevention of intimate partner violence. This is made possible by a Utah Department of Health grant. So right now, Marty Liccardo is going to be presenting with us today, talking about social norms in primary prevention of intimate partner violence. He's a men's engagement specialist from the Utah Department of Health, talking about our 5 primary prevention areas. So this is what we're focusing on. This is what we found from our needs assessment. Some areas of focus. We're in the understanding social factors. So next week we will be meeting again, and Marty will be getting a little bit more in depth about cultural influences, and we'll have some breakout sessions and be talking about that next week. So hopefully you can all join us. Coming in October, we'll be talking about language and then talking about policies. There are no disclosures. Marty doesn't have any disclosures. Myself and Linda also do not have any disclosures that we need to let you know of. Talking about social norms. Part 2 next week will be more delving into those cultural differences, getting in smaller groups and talking about them.
Awesome. Very excited to spend the next 45, 50 minutes with you. I will be asking a fair number of questions of you. Saw Kathy Franchek's program. She did an incredible job starting this conversation, and I hope to build off of that by adding in the complexity of social factors. Understanding social factors attributed to IPV is what is kind of boring name to how we talk about this, but I said, how is this still a thing? Is my subtitle. How are we still in the place we're at when talking about social influences and factors that contribute to kind of the misunderstandings of IPV, but also becomes basically a barrier to us starting to challenge it and help people of experience. A little bit about me is I've worked in the field of violence prevention and intervention for about 22 years. I started at the Rape Recovery Center of Salt Lake County after I graduated from the University of Utah and worked as a victim advocate there and also a community educator. I then went on to the Utah Coalition Against Sexual Assault, where I started working in men's engagement work, how to get men more actively involved in violence prevention work, and I trained victim advocates for the state. And I also, at that point, took a job at the Rape Recovery Center doing hospital response. So I have some experience in direct service with victims of sexual violence, but then my career shifted pretty significantly into primary prevention. And I've worked for the University of Utah, Duke University, and the University of Maryland at different times, doing primarily men's engagement work related to violence prevention. I've learned a bunch of stuff. A few years ago, had a bit of a crisis of conscience about how we do this work. So I'm going to talk to you about men's engagement, but I'm going to do more of that next week and highlight how men's roles in this have been impacted and affected, and why it's so hard to get men actively involved. Today, we're going to spend more time talking about just broad-based social factors that influence our personal thinking and our cultural and social thinking on the topic of IPV. And this is a big topic, so tuck in. So before we begin, I want to say that this topic is too big. Just like Kathy, adverse childhood experience, that alone could be its own class. We cannot possibly cover this issue with justice. So what I'm hoping to do is just kind of whet your appetite to wanting to learn more about this. Our goal today should be curiosity. I want you to have more questions than answers today. I want you to have some new or at least shifted perspectives on this topic after today, and my guess is you will. And finally, I want us to begin with some small amount of action. You don't have some kind of first step, it's less likely that this continues to move. We need high dosage, continued messaging, and then some action steps folks can take. So I will leave you with that too. I often like to say that I hope I leave you more confused about this topic than you are right now. Because if you think you understand it, you probably don't, because I've been working in this field for 22 years, learning new things all the time. Additionally, this field has broadened so dramatically in the last 20 years that even I've been part of it. That when I started in 1998, we didn't have the neurobiology of trauma. We didn't understand any of that. We didn't understand adverse childhood experience. We didn't understand social determinants of health. All of these things play such an active role in recovery and in resiliency, but also how we do prevention work. It's dramatically shifted. So we are a young movement and field of education and interest. Hopefully you'll come along with us as we move through that. Before I start, I want to say something about heteronormativity, heterosexism, binaries. The reason I bring these topics up is a few years ago, as I was doing these projects, programs, presentations that I had done for a long time, I started getting really strong critiques of my language, often by very queer college students in the colleges that I was working for and talking to. And they said that my presentations were heteronormative, heterosexist, and I was using binaries. While I am very well aware that there are gender variant folks in this chat, in Utah and in the United States. Problem is not that we as a society or as a culture or community are binary to heteronormative heterosexist. It's that sexual violence is. That when we talk about sexual violence, it is in a heteronormative way. We think of it in a heterosexist way, and we often use binaries. And so as I talk to you today, prepare that I will use some of those terms. I'm very well intentioned, first off, and I'm also very aware of what I'm doing, because unfortunately the crime itself is very heterosexist, and that includes how we think about it and colors how we think about it. And I'll prove it to you, I promise. And I also want to talk about prevention versus intervention. Kathy did me a great service last week by talking to you about ACEs, because oftentimes I'm charged with going into high schools and colleges to prevent rape and sexual assault. Most people are sexually assaulted before their 18th birthday. Many people experience victimization when they're children. Of a variety of different kinds. So while we are trying to do prevention of future harm, we are also always doing some form of intervention, because sexual violence and dating domestic violence, interpersonal violence, is unfortunately a little too commonplace to act as though we can ever truly prevent it, at least in this contemporary time in the short term. I will go into a little bit of differentiation, just like Kathy did about the difference between prevention and intervention, but since she did such a good job, I will differentiate, but know that I'm talking about both and. This is a bit of a soapbox conversation for me. This is one of those things that I want to start screaming from the rooftops. How we think about this and talk about this needs to shift and change. The way we're going about trying to educate on it is often ineffective, but I'm going to say some things today that my hope is many of you have some trouble with. I hope that I challenge some folks and I say some things that not everybody agrees with. I know that we have a bunch, there's at least 50 people signed up today, so I know that we're going to have a great deal of perspective and information and intelligence and experience. Please share that. Just because you disagree with me doesn't mean we shouldn't continue to dialogue about this in an in-depth way. I still help out with victim advocacy trainings in the state of Utah, and whenever I start my presentations for new victim advocates or forensic nurses, I always say, my hope is that some of you will love me and think I'm hilarious and charming, and some of you will hate me. Because when you go into a hospital response situation or when you work with victims in crisis, you're going to work with people you both like and don't like. And figuring out how to work with them while providing the best care and service for survivors or your patients or whoever we're talking about, while also making sure we are progressing this movement to get that care and build resilience and recovery for survivors and secondary survivors, and more importantly, reduce perpetration. I don't mind if you dislike me in that process. We'll learn from each other. And let me just say too, next week when we talk about men's engagement, I'm going to spend a great deal more time saying that's the actual focus we need to have. Jamie said that my title is Men's Engagement Specialist. We actually just changed it about a month ago to Community Engagement Specialist. We did that for a very important reason, because men don't respond when they feel targeted or attacked. They just don't. And we're going to talk about that in more detail next week. But when people used to ask me, why is there a Men's Engagement Specialist? What is the reason? Why are you doing that job? I always say, because 98% of rape and sexual assault are perpetrated by men. Now, did I just say that 98% of men rape? I did not. Most men don't. Most men are wonderful, amazing people. Some of my best friends are men. I'm a man myself. So it's not a criticism of men, except to say men make up a grossly disproportionate amount of the people who perpetrate sexual violence, which makes sexual violence and interpersonal violence a men's violence issue, not a women's issue. Now, this is not to say that women and people who are gender variant don't commit acts of sexual violence. They do. And I don't want to minimize that. But there's something going on when 98% of rape and sexual assault is perpetrated by men. And let's say maybe it's as low as 90. That's still something going on with men as a gender or men as an identity. So we'll talk about that in more detail, but that's why my job exists. But men are also impacted to a large extent by this in ways that we don't think about. I often like to point out too, that when men are afraid of their own safety, who are they afraid of? No, men are afraid of other men. So even when men are the targets of violence, they're still afraid of men. So this is the issue. It's a men's violence issue. And if we spent far more time thinking about the perpetrators of this issue instead of the victims of this issue, I think we would do a much better job at preventing it. We talk about prevention of sexual violence. If I said I was going to do a prevention program of sexual violence tonight at the city library, now we know that's not possible because of COVID, but if I said I was going to in non-COVID times, what would the makeup of the room look? 40 women would pile into a room and ask, what do we do to prevent sexual violence? Now, that's not unimportant, and risk and physical and sexual safety for women is a critical issue. And I don't think that would be a bad conversation. But that's not prevention, that's intervention. Prevention would be 40 men piling into a room and talking about sexually aggressive behavior and sexist language and sexual communication and healthy relationships. That's prevention. How do we teach men and women and people in general, all of us, human beings, to start to cultivate how we communicate and relate to each other? It gets really tricky. I added this slide in here because I'm also going to talk about things that are going to make you all unhappy. And sometimes I get really, really challenged. And I think that's a good thing because I've learned from it. Sometimes when I want to talk about this issue, I feel like this. I feel like this most of the time. Sometimes it's like this. Some things to consider: people's response versus reactivity to IPV. This is a tricky thing to talk about interpersonally. This is a taboo topic, and we're going to talk about why in a few minutes with a few activities and that we're going to run through. But this, like, how do people respond when you bring this up? Normally people shut down. You know, if I used to, when I was flying on a plane, if I didn't want to talk to the person next to me, I would tell them what I did for a living. I work at the Rape Recovery Center, and usually it would immediately stop the conversation because they don't want to talk about these things. So we've already made the notion of interpersonal violence taboo. We've also deeply stigmatized victimization and perpetration in a way that we can't talk about it. And this doesn't benefit anybody. How do we talk about this? I used to joke that I wanted to make interpersonal violence dinner table conversation. Now, I don't really want to do that. That can ruin a meal and certainly a holiday, right? But I do think getting more comfortable talking about this uncomfortable conversations takes practice and skill, and figuring out how to talk about those without traumatizing or triggering certain people who've had experiences or upsetting people who the topics can make uncomfortable. It's a tricky, tightrope-y kind of thing, but we need to start thinking about it. Why do people respond that way, and how do people respond? That's how we need to start practicing this. So meeting them where they are or holding them accountable. This is more a topic for men and men's engagement, and we'll talk about this in more detail, but I want to talk about meeting every person where they are with this topic. As much as it's happening in such an alarming rate and in an alarming way that we need to talk about it, we also need to understand, like, forcing people into things that they're not ready to do does not work. I got my master's degree in health behavior change, both individual and group health behavior change. And one of the things I learned in that master's program was people don't change their behavior. Okay? That's the problem. That's the issue, is we need to figure out what is the best and most motivating way to get people to start to move this. Some people are going to be ready to talk about this and some aren't. I also want to briefly just have you think about, as we talk today, structural versus individual accountability. This is such an interesting topic as we talk about Black Lives Matter right now as a nation. We have a lot of opinions and ideas about blue lives, black lives, all of these things. And I know all of the personal is very political here. So in an effort to open that up, to say, when we talk about white supremacy, male supremacy, gender supremacy, all of these kinds of things, we need to understand how to separate the structural barriers and issues from the individual. Sometimes they're the same, but sometimes they're different. I often find that if I have to talk to an individual about accountability, if they are a white person, but they are also a person who's suffering from extreme financial discrimination, that they don't connect very well when I start to say that they are privileged. So how can I talk about that structural issue of white privilege while also understanding that they have barriers of wealth access that is, harming them in innumerable ways and other ways? So how do we start to deconstruct that kind of thing, or just honor that person by listening to their understanding? Additionally, we have some intellectual bias with how we talk about this. The very notion of talking about all of these topics and using these fancy words, I really love the notion of changing the terms of, like, shell-shocked to as we progress as areas of study and research, we change these terms to be more accurate and authentic. I love this language shifting because I think it really helps us understand this stuff better, but also honoring the fact that not everybody has the opportunity to learn these things, and it can feel demoralizing, and they can feel like, I'm not ready to have this conversation if we challenge them on every piece of language. Let me just tell you this, people. I started working at the Department of Health about 4 years ago. And when I did that, I used to work at the University of Utah before that, which is a fairly progressive, broad place. And I went to the Department of Health, and I started working in San Juan County and in Tooele and in Tremonton and in the Uinta Basin. These are all amazing places with amazing people doing amazing work. they often have different ways of thinking and moving around the world than I do. And what I did and had to do in order to be as effective as possible at integrating prevention efforts on IPV into those communities as best I could be supportive to do that. Because by the way, they were already doing great work there too. We have some bias associated with that as well, from places of privilege, from cities, from urban areas. But I had to become radically centrist in my professional life. It didn't shift my own I have my own politics and my own way of viewing the world in my personal life, but my professional life had to shift to become more centrist and open to a broader way of dialoguing. That can be a very difficult thing to do. But I found it a more effective approach, just me personally. And I'm throwing that out as something that was a helpful learning tactic, especially with people who are the most difficult to push and share some of these ideas with. And a lot of them didn't agree with me, even after we spent a lot of time talking together. But what I did want to do is make sure that the resources we had and what was happening nationally and through research was getting into those communities, and they were able to use it and then shift it to meet their community and cultural standards. That was important as well. Okay, I also just want to briefly touch on intent versus impact. Both of these things are very important, but I sometimes feel like people act as though intent doesn't matter. And intent really does. Intending to be racist is different than accidentally being racist. In the end, the impact is the same. There was some racism, but how we have that conversation with a person is pretty important. And a person intending to cause harm, to me, is very different than a person accident. Having a desire to get an intent is really important. And finally, what are our shared goals? I find this to be the most effective thing in the world to go, instead of what do we not have in common, what do we want to do together? What is the shared goal we have in trying to reach an outcome here? A good place to begin is this. This is the approach we take at the Department of Health. We use a public health approach, and I'll go into some detail on that during this hour we're together. We use a strength-based model. What's working? What is good behavior? What do we want to focus on the positive in most of these cases. We want to focus on what people are doing well and enhance that instead of focusing on what people are doing wrong. When we focus on what people are doing wrong, they start thinking about that. When we focus on what they're doing well, they can keep doing it. We also have a goal of moving the needle. We don't have a goal of true perfect outcomes. This is what we want everybody to be doing, but saying we want to move the needle on the things that are not working or harming. If there's no services at all in a community, I'll give you an example of there's a health region of 5 counties that have 1 sexual violence health educator in them in Utah, in central Utah. I mean, that is not the same as Salt Lake City. While we don't have nearly the sources and personnel we want to do the kind of work we want to do on violence prevention, we are not suffering the same affliction as this community. And so how do we make sure we understand that? We're going to talk about social norming today, because understanding social norms and societal norms is a really good first step into the assessment and evaluation portion of how you should be structuring your intervention strategy or your prevention strategy or your policy building. All of this relies on understanding the community you're trying to target. And I use that term community very loosely. We tend to say community all the time when community can mean a million different things to a million different people. It can be a community of LARPers in Liberty Park as a community versus the community of Utah. Like we have to start differentiating how we use that term and idea. Additionally, I like bystander intervention strategies in general, but like how do we engage people in an issue where we have culturally and socially been taught to ignore to engage? And to me, building these intervention strategies for people and lay people on the side is a really important first step. But it also, to me, it's the way to connect people to their communities. This is your community. You have an ultimate responsibility to get involved and help people and stop harm and produce support. That unfortunately, it shouldn't be a community value to ignore somebody. It should be a community value to get involved and help. Media literacy, social media especially, is really critical, and health literacy. Understanding what those two things mean. And by the way, unfortunately, I'm not going to go into detail on either of those things. So star those in your little notebooks right now and start doing some research on those. And you can use the CDC or the State Department of Health. I imagine the University of Utah also has some great resources on these. I'll also use the term health equity and social determinants of health. If you are not uniquely and deeply familiar with these terms, this would be a great place to start educating yourself on. And there's actually really good trainings in the Department of Workforce Services and the Department of Health that you all can just get involved in. And I know that they're making those trainings virtual as well, but really good in helping us start to think more broadly on how we have been approaching this. Cultural competency and humility too. This just goes into what I was saying before about like, know that every community you go into is not going to respond perfectly or wonderfully to every approach. We have to tailor them. I often like to just say this in this way. You would not do the same tobacco prevention program in Salt Lake that you would on the Navajo reservation. It would be, it's just a different program. The flyers, advertisements, media messaging would all look different. So understand that all the approaches have to look different. I'll tell you, if you ever look at indigenous smoking cessation programs, they're really unique and thoughtful and interesting. They would not work in places that aren't indigenous. So a good example of that. And I like the idea of cultural humility. I used to say cultural competency, and somebody challenged me on it and said, what about cultural humility? And the difference they said was cultural competency means trying to understand a culture. Cultural humility means we can't possibly understand anybody's culture, even our own, because they shift and change. They are plastic, organic, changing things. So we need to be adaptable to that as well. And that's a much better way to go. Cultural barriers I'm not understanding. That would be a cool and neat opportunity for me, as opposed to saying, teach me about your culture. And by the way, when you start to build those bridges of cultural humility, you also create new cultural structures as well, cross-cultural structures. I really just wanted to highlight primary, secondary, and tertiary prevention from the perspective of society, that Kamara Phyllis-Jones does a really good job in this. And I can send you a link to this and a video of her going into deep detail on it. And she's way smarter than me. So I would advise you to listen to her talk about it. But she talks about prevention being, let's say the health issue you're dealing with is kids falling off this little cliff, okay? I realize this drawing is rudimentary, but it's actually helpful because it makes it really easy to understand. What you want to do if you were doing primary prevention, you want to stop people from falling off that cliff, you build a fence. Now these little rascals are going to be messing around and they're going to hop over that fence occasionally. So you want to make sure there's a secondary prevention strategy, that net, something to catch them to prevent them from harming themselves from falling. Now, over time, that net's going to get holes and it's going to have problems and they're going to fall through that net. So you want to make sure there's medical services, medical care, and tertiary prevention services at the bottom of that hill for the kids who fall through and get hurt. Okay. Now, Kamara Phyllis-Jones, being as smart as she is, also knew that this wasn't quite as depth as it needed to be to understand true dynamics of social determinants of health. And she said, the problem is not all of those communities are equal, that some communities don't have a fence. Some communities don't have a net or an ambulance. Some communities have kids who are far closer to the edge of that cliff than other communities. That like these different exposures and opportunities outside of just the kids being kids is a really important thing to think about too. What structural things, barriers are in place that will make it easier for people to fall off that cliff of good health? And when we start thinking about it more broadly, understanding like it's not just primary, secondary, and tertiary, there's all sorts of things we need to do before primary and after tertiary that are critical as well. We also use the socio-ecological model. We want to look at individual behavior, how those individuals impact relationships, how those relationships impact communities, and how those communities impact society, and vice versa. And so we want to do targeted focuses on individual, relational, community, and society, but we also know that all of those things impact each other. I could literally do an entire hour and a half just on the socio-ecological model. So I want you to understand, I know that there's probably some social workers here. I know that there's probably potentially law enforcement, some other folks who might be listening. Important to understand that oftentimes we use different language, but our messaging is often the same, that we are meaning the same things and talking about the same things. So sharing that language and nomenclature, but also our ideas, can be really valuable in understanding how to do this. So I could do a community level prevention effort or prevention strategy that has deep impact on individuals. I could do a societal level one, for example, a policy change on people's access to healthcare that would all of a sudden impact every single circle of this model. So understanding that these models work together, but we historically, especially related to IPV, tended to focus on that individual ring. Now, the problem is individuals who experience sexual violence or perpetrate sexual violence impact relationships. Relationships are impacted and affected. Families are impacted and affected. That affects and impacts communities. And so you can see how that kind of stuff moves back and forward. But what I like about having a theoretical framework on this is it guides us. Are we focusing too much on the individual and forgetting? And one of the things the CDC and primary prevention asks you to do, especially contemporarily, is start moving to those outer rings. And this series that you all are participating in is doing just that. You're going to have sections talking about policy. We have not done that in this field in any real way. We have occasional dialogues about it during the legislative session, but incorporating it into everyday prevention modeling is really, it's new, and I'm very excited about it. I'm excited about thinking about how policy can be used as a tool to help individual health. And we all know it can. So anyway, if you want me to go into more and more detail on how much I love the SEM, I will do that. So call me anytime and we can talk about social ecological model. It's a really helpful tool. Okay, so social norms, the whole reason you were here to talk, I was here to talk to you today. Social norms are values, beliefs, and attitudes and behaviors associated with different topics, ideas, people, cultures, customs. So values, beliefs, attitudes, and behaviors. That's how we would define social norms. We all have this idea, are social norms good or bad? What do you think? Anybody think social norms are good or bad?
I think they're both. At times they're good, and at times they can be bad.
Right. And this is the problem with culture and society. And some things that used to be good, we would now read as bad. Things can actually change over time. Language is such a good example of that too, that how we refer to people of color now was very different 20 years ago and 20 years before that. That like we've changed our language to meet different cultural values, attitudes, and ideas. I also say, like, if you go to a foreign country and try and shake hands with somebody in an Asian country where bowing is more normal, everybody will look at you like you're crazy and you're doing the wrong thing, and there'll be embarrassment. When in reality, it's understanding like these customs are neither good nor bad, they're just what they are. But some of them can be bad, and we're going to get into some of those attitudes, ideas, beliefs, and behaviors that can actually cause harm. So one of the things to know is that norms influence behavior. So cultural norms have an influence on people's everyday behavior. Norms are often misperceived, over or underestimated by a majority. So we see this a lot with alcohol in high school and on college campuses. That if it's a party school, students perceive that every student binge drinks. And then when you actually do surveying and research on it, you find that sometimes something like 60 to 70% of those students, even at a big, like raucous party school. So that majority overestimates the amount of bad behavior, and that behavior influences their behavior. Well, this is a school where we all really go to town on the weekend and drink a lot. Then that becomes the norm. I'll give you a great example. I worked at the University of Maryland. And it was very common for students at the University of Maryland to go to this one bar. It's called Cornerstone. It was one of those nightmare college bars right across the street. And they would do 21 shooters on their 21st birthday. They would attempt to drink 21 shooters. Shooters are like kamikazes. They're a mix of shots. They tend to have less alcohol than just shots, but it's not a good idea. It's too much alcohol. Students usually get to like 11 or 13 and pass out or have to get carried home or go to the hospital because of alcohol poisoning. Very scary. But the cultural normality of this tradition caused students to behave in a way that they wouldn't normally behave. So this is one of those things that, like, if we could challenge the tradition, we can actually decrease the amount of unhealthy drinking. So again, like the actual tradition was causing the unhealthy drinking, not just a student's bad attitude or behavior or whatever. Okay. Misperceptions encourage people to conform to false norms, attitudes, behaviors that are adjusted to conform to what is incorrectly perceived to be true. We see this a lot with rape mythology too, with why we hold women accountable for men's sexual violence, or why we hold victims accountable for rapist sexual violence more accurately. So, and then correcting misperceptions allows individuals to act in accordance with their actual beliefs, which are more often positive and consistent with prevention goals. So this is the other thing I want to say. Most people do the right thing when given the opportunity. and especially when they are free, of social norms that encourage or increase behavior. I mean, this is like a much more heady version of peer pressure, right? But it's very accurate. The dumbest decisions I've made in life were usually encouraged by friends. I don't know if anybody else can resonate with that. But I never decided to party really hard by myself, right? Or anyway, I'm giving too much information about myself, but you get the point here too, that like we have an opportunity with social norms that oftentimes we perceive this as the normal thing, so we don't challenge it. And if we challenged it in a variety of different ways, and in ways that we didn't target a person or humiliate or embarrass or scold, we actually start to see people make better, healthier choices. By the way, I told you that one of the approaches we like is the public health approach. I like the public health approach. I like a health framework when dealing with interpersonal violence for this reason. It is not about what you're doing as good or bad. It is about what you're doing healthy or unhealthy. Is your behavior pushing you towards your goals and things that make you feel good and things that are good for you? Or is your behavior or choice or attitude pushing you towards things that are harming you or creating dis-ease in your life? This is a much better framework. I like removing stigma and shame. Stigma and shame are the biggest barriers to healthy choices and behaviors. We can see that with a whole host of different things. I have a 2-hour PowerPoint on what we commonly refer to as pornography, but I actually prefer the term. See, I'm using a different term now, sexually explicit media, because I think it's a much more useful term. And pornography has been so stigmatized that you can't even talk about it. People get so upset, and then we have all these misconceptions. We don't go off of research, we go off of anecdotal information or scary things or things we saw that upset us. When in reality, like, let me just give you one example. And this is one of my favorites. What is the average age of first download of hardcore pornography for young boys? What do you think? What age?
12.
Oh, that it were 12. It's 10.
Oh, gosh. That's sad.
Now, this is the moment where everybody's like, 10 years old? That's too young. It's too young. I agree. It's very young and way too young to be experiencing graphic sexual depictions. However, we tend to have this like the sky is falling attitude. Young kids have been looking at and again, this is one of those moments where I work with people who are vehemently anti-porn and anti-pornography, and I work with people who are very supportive of commercial sex work and supporting sex workers' rights. These people don't agree with each other. They have very different viewpoints, and good viewpoints on every side of these issues for protecting people. And one of the things I often start with is, what can we all agree on? And all of us can universally agree that 10 years old is too young to interact with that kind of media. So what do we do to protect people who are under a certain age? We can all get together, and we're working on some great projects. But I also want to say a 10-year-old who sees active sex is not scarred for life. And if they and honestly, what I often say to folks is, what worries me is that after he sees this, and it's he, by the way, because most girls don't see that at age 10. When he sees this, he already at 10 knows to feel ashamed, be embarrassed, not talk to anybody about it, and not search for a way to protect himself in the future, right? He knows to be embarrassed, but also, so what we're doing is pathologizing young people's curiosity about sex and giving them one outlet that is potentially damaging and harmful to them to go seek it out. I hope, and by the way, I have a nuanced view. When I talk about pornography, I always say it is the most awful, terrible, horrible, greatest, wonderful, most amazing thing ever. That's the problem with sexually explicit media. It's tricky. But I will tell you this, our attitude about sex and sexuality is also a risk factor for victimization. Because I also know that when I noticed that there's a lot of registered nurses. So when I asked this question, I'm sure you would all feel comfortable with this topic. But I will usually go into a group of people and ask the question, what is sex? And in Utah, whether I'm talking to 18 or 85-year-olds, it usually takes me somewhere between 3 to 5 minutes to get a group of adults to say the words penis and vagina. Usually they say 2 people being intimate, 2 people sharing love. Yeah, but if I'm asking explicitly, specifically, what is sex, it's penises meeting vaginas, right? And we know this. This discomfort with just dialoguing and talking about body parts, penises, vulvas, vaginas, anuses, are used for a variety of different things, as you all well know. Whenever I do this for nurses, they answer immediately. One of the things I often point out is like, that discomfort, if we are not comfortable talking about sex and sexuality in a clinical or educational framework or format, how can we talk about it in times when we're insecure or being intimate or nervous about something, especially for young people? We set young people up for failure with sexual communication. And then we do all these presentations on consent, but don't actually teach them how to have the conversations, which are more difficult. And consent is so infuriating for me because we act like it's simple, and it is the most complex, frustrating thing in the world. And then we tell children that they messed up or they did it wrong, instead of preparing them to have very difficult conversations. And again, I am 43 and I still have difficulty with certain direct communication with certain people in certain settings, right? So like, why am I holding them to a higher standard? I also briefly, when we talk about risk and protective factors, just want to say risk and protective factors are the next section that Kathy was talking about. She talked about resiliency, and this is the format with which we want people to think about primary prevention. Characteristics that increase the likelihood of poor health behaviors are risk factors. One of our colleagues during a training referred to them as vulnerability factors, which we loved because that's really what it comes down to. What's making you vulnerable to poor health outcomes or poor life outcomes? And then we talked about protective factors, characteristics that decrease the likelihood of poor health or behavior outcomes because it provides a buffer. And this same person said, how about resiliency factors? Factors that increase your ability to cope when these things go wrong. Because by the way, you know, we talk about how do we prevent things. You can't always prevent things. Hurricanes, they happen. So some form of resiliency has to be supported and nurtured. And so how do we start to build these resiliency factors? Well, one of the things we know is you already have protective factors that you can identify and then build off of. And so how do we start to support people by saying, oh, these seem like risk factors for your health. They're not judgment calls. It's not you making bad decisions. Smoking's not you making a poor choice. It's kind of the problem with it is it's a risk factor. It makes you vulnerable to other health issues, and you want to play with your kids and hike up a mountain and do these things. Smoking can get in the way of that. You know, so how do we help people to make the best choice? And when we talked about before with social norms, when given the opportunity, oftentimes people will make those, especially when given the support structures to do it. One of the things that Kathy didn't mention too is when we talk about building resiliency, the best thing you can do is buffer with people's support around you. You know, one of the first things people have to do when they go into recovery from alcohol abuse is lose all their friends because their friends are their partying friends. Imagine what that would be like to lose your entire support structure while going through something difficult. I mean, this is one of those moments where it seems like, why doesn't this person just stop this behavior? It's harming their life, and they got fired from their job and they got in a DUI. And it's like, understand changing behavior is difficult. And this is when that empathy factor really comes in strong. Okay. Understand too with risk and protective factors, it's an additive effect. Not all risk factors or protective factors are created equal. So the more risk factors they have, the more risk, the more protective factors, the more likely to protect themselves. Not everything's equal. So the same risk factor is not the same as another. And they're different for different people. The shared risk and protective factors. Oftentimes people can have both risk and protective factors. And finally, supporting resiliency is the way we want to go. Understand too, I don't have time to go into these in too much detail, but I think there are online virtual trainings in the state that I have been through that are amazing. And even just starting the process of taking the time to learn about these things. In fact, what I'll do next week too is give you some resources that you can go to watch some videos, just some good people explaining this, but actually go watch a bunch of people. It's a really important topic, and it helps us understand that we tend to think about people's health and people's behavior individually, but when you look at social determinants and health equity, you realize there's a whole lot of extenuating circumstances that are impacting a person's ability to do the healthier thing. And this is just a model from the Bay Area Regional Health Inequities Initiative, but to explain social determinants. One of the reasons I just wanted to throw this up there and show you is I love this image because what we always focus on in health and healthcare, and by the way, including in my area, even in violence prevention, we focus on risk behaviors, disease and injury, and mortality, instead of focusing on social equity, institutional inequity, and living conditions, which are all buffers for good things or potential risks for harm. So I wanted to go through some definitions. I wanted to go through this to talk about how when we talk about interpersonal violence, we don't often think of these things in the same way. And a couple of things I wanted to highlight are, we know what rape and sexual assault are, although these definitions are the Utah state definitions, and they're not good enough. But when we talk about harassment, any deliberate or repeated behavior that is sexual in nature or gender-based and unwelcome, but especially with these things in our lives right now, these wonderful devices that connect us to people across the world, they also are incredibly risky, especially for young people and developing adolescent brains and the decisions that they make in terms of how we start defining that blurry line between harassment and abuse and assault. I like stalking as a concept because people don't think about it in more detail. Any repeated behavior that can cause a reasonable person fear, it's usually not a definition people think about, but the problem with a lot of stalking behavior is we have normalized it. We have normalized, I often will say to somebody, if I brought you flowers, is that a nice thing to do? Well, yeah, depending, right? Do you want the flowers or do you not? What was my intent to, and what was the person's desire to receive those? Those kinds of things matter. Oftentimes too, you'll hear, oh, so-and-so asked me out. I didn't want to embarrass him and he kept asking me. It was really annoying. And you're like, actually, that was a repeated behavior that was causing you discomfort and potentially fear. But the problem is a lot of behaviors that fall under stalking are technically legal. If you work at McDonald's and they keep coming to McDonald's, it's not illegal for a person to go into McDonald's unless they're asked not to. And so how do we start to talk about engaging with people and teaching boundaries? You know, prevention for that kind of behavior can start really early, but usually people wait till something gets really threatening or bad, and that's when it's harder to fix, or at least more complicated. I shouldn't say harder. Finally, domestic violence. I wanted to point out that our definition is controlling abusive, aggressive behavior in a romantic relationship that can include verbal, emotional, physical, sexual abuse, or a combination of those. I do not like the term romantic relationship there. It infuriates me. Because have you all ever had a friend who was like, you can't wear that. I'm not going out with you if you wear that. What is the difference between your friend doing that and someone you're having sex with, or kissing, or snuggling with? Right? The problem too is we have turned domestic and dating violence into a separate thing, when in reality, relational violence can be parent to child, can be friend to friend. How do we start thinking about relational abuse and violence in a different way? I'll also tell you this. I was at the University of Utah about maybe it was like 3 years ago. And a student who I used to work with when I worked there asked me, can you come do a presentation on domestic violence? And I said no to her at first, because I said, I'm an expert on on sexual violence. There's better people to talk about this. And she begged me. And finally I came to her class to sit on this panel. And I'm sitting next to a DV detective from Salt Lake PD, a caseworker from the YWCA. I was the dumbest person on this panel, hands down. And at one point, a student within the first few minutes asked that normal question, why would someone stay in a relationship like that? Why would someone defend a rapist? So they said, why would someone stay? And then all these experts started giving all these wonderful reasons why a person would stay: controlling behavior, economic abuse, they care about their perpetrator, they're in a committed relationship that's meaningful to them, all of the different reasons. And I'm watching all these students nodding heads, all these 18 to 24-year-olds like, oh, that's why a person would do that. Well, here's the problem with that. I got mad when I was watching this because they were correct, but I said to this group, you know, this is frustrating to me because I want to ask you all a question. Have any of you in this room ever stayed in a relationship longer than you thought you should have? If I asked you all this question, every hand in that room should go. Every hand in this chat should go up. We have all done this. And did some of the behaviors in some of our ex-partners or even friends, did it constitute abuse? Some of it might. Maybe it wasn't physical abuse, maybe light social abuse, but like this notion that we're any different than someone who could be a victim of sexual violence, we other so hard in this, we have normalized aggressive, violent behavior in relationships as commonplace. It is not abnormal to be in an unhealthy relationship, bordering on abusive. And so, but for some reason, when we have this stark differentiation between domestic violence and not a great relationship, and really that's very effusive. It's very murky. And so we need to stop talking about it like this. And oftentimes too, when we think about severe domestic violence, it's not the actual violence that's the biggest problem. It's the fact that this person doesn't have options to leave and a place to land, and doesn't have a safe environment for their children, and doesn't have an ability to financially pay for their kids. These are the things that complicate domestic violence in more severe ways. But we talk about it in this really simple way. So let me say, we have a ton of implicit and explicit bias when we talk about this. Let me prove it to you. When I said this to you before, I can prove to you that this binary and gendered thing are real. Let me ask you to do me a favor. In your mind's eye, picture a victim of rape. What does that person look like? What's their age, race, socioeconomic status, gender? Get an image in your brain of that victim of rape. Now think of a perpetrator of rape. What does that person look like? What's their age, race, socioeconomic status, gender? Get an image in your brain of that person. I can't truly do a straw poll here, but let me tell you what actually happened, because I've done this 100 times. How many of you do you think thought, when I said victim, thought of probably all of you, okay? And my guess is many of you said a white woman between the ages of 18 or maybe 16 and 28, okay? When I said perpetrator, how many of you, who did you think of? How many of you thought of a child when I said perpetrator? None of you did, by the way. None of you did, even though we have 3 facilities in the state of Utah for child perpetrators of sexual violence. Now, I'm not suggesting you should be afraid of children. Most of them are not committing acts of sexual violence. However, this is that bias. I bet you thought of the creepiest dude possible. Guess what? That's not accurate either. And actually it is and it isn't, right? Because victims can look like anybody and perpetrators can look like anybody. And I like this brief exercise because it's not about being like, see, I proved it, you thought wrong. Because women between the ages of 16 and 28 can be victims of rape, often are. So these are those moments where you say, this kind of implicit bias is not necessarily good or bad, but it impacts our ability to see people as victims or perpetrators. And this is just asking you that simple question to start off this dialogue. How do we start thinking about this differently? That is a form of individual and interpersonal. You're looking outside at somebody else and making a judgment call. How about this? How many of you in this room think that it's potential or possible that someday you might develop cancer? Is that a possibility? How many of you think it's possible that someday you might develop heart disease? Is that a possibility? Yeah. How many of you think it's possible that someday you would develop alcohol dependency? Isn't that different? My guess is the vast majority of you we're like, no, not me. I would never do that. That would never happen to me. And it's because we have a different social attitude and norm associated with alcohol and drug abuse and substance abuse than we do about these. We look at cancer and heart disease as these things afflicted on us, and alcohol is a choice. When in reality, what causes all of these ailments? Behavior, genetics, and exposure. Behavior, genetics, and exposure are the things that cause all of those. We are all as likely to develop cancer as we are to develop substance abuse. But it's such an interesting question. And the reason I picked these 2 questions specifically is I want you to think about, how do I look at other people and assess their behavior and their worth and their character upon choices? And how do I even have blind spots about my own self? And this is not to say, so this is one of those areas where certain people will disagree with me and say, well, I wouldn't develop that. This is different. And I go, to be honest, it's not different. That from a health standpoint, genetics, exposure, and behavior cause all of those things. The lesson to end on today is, how do you start to evaluate social norms, the processes, and how they impact your understanding of IPV? It starts with yourself. It starts with a real deep look in at how you're viewing these kinds of things, and how you might have thinking errors and misconceptions or incomplete thinking on this. I kind of want to leave a minute or 2 for people to ask if they have burning questions. And I've set this training up so that, don't worry, next week we can build right into it. And so this was the concept of othering related to IPV. The only thing I wanted to share was just that we other dramatically. And one of the first skills, if you learn nothing else from today, is that you start thinking about how you're othering in relation to thinking about this issue. How are you othering and not thinking about who can be impacted by violence? How are you othering by thinking, even when we talk about perpetration? You know, one of the first things we always hear is when a person is accused of some form of sexual aggressive behavior, my friend would never do that. I could never see this person doing that. Instead of asking what happened, Like, what are the details of this? It gets more complicated, but we need to start thinking about how we're impacting and affecting that. I will tell you, Time's Up and the Me Too movement have had a really profound and powerful impact on asking some of these questions more broadly. We're moving into a good, and I will say in some ways they have made this difficult too, because when we talk about men's engagement next week, I'm gonna share with you a lot of details I hear from men where men feel like, I can never bring this up. If I say anything or challenge anything, I'm a rape apologist, or I'm attacked for it. And so, and at the same time going like, why do you think people are so angry and upset? Maybe this is like righteous anger. But at the same time, how can we, as people working in this field, start to open this conversation to include, how do you? I often like to say, like, what is forgiveness for people who commit acts of sexual violence? Is there? Or are these garbage people that we throw away? Because that's not really useful. You know, in the same way that someone who was a drug abuser and committed crimes, this is not a garbage person. This is a person who needs help, and there are extenuating, complicated reasons that they made the health choices and behavior choices they made. Okay, I just like this question, and maybe this is a great place to kind of shift down too, but what if we stopped focusing so much on outcomes? Like, here's the outcome I want. Now, this is not always possible, because even when people are doing grants or they have job requirements and things like that, we're always looking for an outcome instead of going, how do we shift that conversation and say, let's just open this conversation up to think about this topic differently. How can we invite people with very different desires on outcomes into the same space and move forward in that conversation? This is a real heady request, but my old supervisor, who's no longer with the health department, if any of you know Megan Waters, she's a genius. She used to ask this question a lot, to say, like, what would that look like for you if we didn't burden you in our grants with outcome measures? What would you do differently, and why? What would you look for in your evaluation processes to indicate broader health? I mean, one of my favorite examples of this too is, I was just listening to an interview of a guy who owned he's a CEO of a company, and he decided to, his name's Dan Price. You should look this guy up. He's interesting. But he decided one day to pay all of his employees, to cut his salary and pay all of his employees $70,000. Like, from administrative assistants all the way up to the vice president, like, everybody makes the same amount. And people kind of poo-pooed it. But one of the things he was doing was, somebody asked him how his company was doing. And instead of saying, here's how much money we've raised, which they've done fine, they've increased profits, he started focusing on things like, all of half of my employees now own their own home. 50% of my employees are completely out of debt. And I just think, like, that to me is where we go, is like, we have an opportunity to look at other forms of outcomes to make us think, what would a world look like where it's not just a one-stop shift in thinking? Did we reduce rape? That is an important outcome, but there's other ways to think about this too that we have to. So I like this idea of, like, really hurt your brain thinking about how you can grow from this. And to leave you with today too, just in general, think of one or two things, write them down now, or spend some time tonight. What are some things you can do, individual goals that you could set for yourself for sexual violence or domestic violence prevention and intervention? What can you do today? What could you do for your company that you work for, or for your family? What conversations can you have? Or for your ecclesiastical organization, could you start a dialogue on what are opportunities for creating dialogue on this and moving towards positive, good goals? People who know me know I am not Pollyanna. I am a defensive pessimist by nature, and I like to assume the worst. But this approach is a much better approach at getting towards the goals that we actually have. And I hope at the very least I've given you all some things to just think about. And if you have any questions, my email is at the top of this PowerPoint that they'll send. You can reach out to me at the health department, but I'll also be back next week, and we'll have even more hopefully interesting conversations.
I think one of the things, Marty, you had talked, I know in your slide presentation, you had a video that people could watch, or some of the various links. We can send this out to everybody who's participated to make sure they get it, but just some links so that they can come prepared for next week
I appreciate that. And let me give everybody a heads up with this homework and maybe include this on the link you send.
Yeah.
This is an individual discussing a sexual assault. So I think that we overuse the term trigger warning these days. Like a trigger is an actual psychological event. It's not like I'm offended by that. And we tend to I think in some ways misuse this. This is a triggering thing. This is an individual, it's a reenactment of a person discuss, like talking about a sexual assault on a college campus. But what I want you to do as you listen to this is pay attention to contradictions and how this individual talks about it. Because one of the things I think is so valuable about this video is you will get a sense of how this person uses culture and social norms to support his violence and to not be held accountable for it. It's fascinating, but also it's disturbing. And he swears and says awful things. So heads up.
Marty, that was great. We really appreciate you coming and joining us, and we're looking forward to next week.
Great. Thank you all. It was fun spending time with you today.